So Dr. Jeff Dusek is a professor in the Department of Medicine at UC Irvine and the Director of Outcomes Research at the Susan Samueli Integrative Health Institute. Dr. Dusek has over 25 years of experience leading innovative integrative health and medicine research in the United States. He is the contact PI of a multi-site R01 from National Center for Complementary and Integrative Health to study the effects of acupuncture on acute pain for people in 3 emergency departments affiliated with the BraveNet practice-based research network. Dr. Dusek has published over 100 articles in peer-reviewed journals, and these include journals the National Cancer Institute, Circulation, JAMA Network Open, and others. His research has been widely featured in public venues like the New York Times and NPR. And today he's going to talk to us about his research on acupuncture for pain in the emergency department. So this will be about a 40-minute talk, and then you can hold your questions about the end. Hold your questions until the end, and then you'll be welcome to share them in the chat or out loud at that point.
Okay. All right, I'm going to just get this, share my screen. And side. And all right. Thanks, everyone. Thank you for the invitation to present today. I like talking about this study because it's actually a really fun study. I actually began this work in 2013, so it's one of those processes where you have to keep going and keep at it. So this is a collaborative effort. I did this work when I was at Connor Whole Health, Case Western Reserve University, Vanderbilt University, UCSD, and Albert Einstein were the participating groups. I'm now at UCI. And I'll start with this, just talking a little bit about pain. Pain affects about 100 million people in the US, adults in the US. This is an old number, but there's not a better number, but it's like $560 to $635 billion a year. So it's about 10 years old. So this is pain, all told, not acute pain. So again, the costs in 2024 are going to be higher. Pain is also a public health problem because it allows or has people drive towards medications. It's a major cause of disability, and it also diminishes people's quality of life and diminishes their productivity. Acute pain is an important aspect in the emergency department, or the ED as I'll call it. In 2019, there are over 150 million ED visits. Most were for acute pain, and it's still difficult to manage, although with a lot of efforts, with the opioid epidemic, there's been a lot of issues of reducing opioid usage, but in the ED, acute pain is often treated still by opioids or other measures, but opioids are still part of the portfolio and still part of the guidelines. In a recent study, actually a study of about 2015, found that 17% of people who were opioid naive, who were prescribed opioids at discharge, were still receiving opioids 1 year later. And that doesn't mean every time it happens, but it just says there's a risk. Namely, if you go to the ED and have opioids, it's possible that there may be opioid use later on. So ideally, we're looking for some other non-pharmacologic ways to reduce pain, which goes to this systematic review that was published a couple of years ago. Essentially, they looked at 56 studies. Acupuncture, physical therapy were for musculoskeletal pain, for most of them. 42 studies reported at least one improved outcome after the intervention. 23 studies reported significant reduced pain to control. 24 showed no difference. 9 studies had no control group. Meta-analyses, including 22 RCTs, had a mean difference of 0.46 in favor of non-pharmacologic interventions for reducing pain. The conclusion, however, was these interventions are often effective, but most existing studies are small and warrant further investigation into their use for optimizing ED pain management. So that led us to acupuncture in the emergency department for pain management, a BraveNet multi-center feasibility study called ACUITY. And what is BraveNet? So BraveNet is a practice-based research network with the idea to conduct and disseminate high-quality practice-based research that evaluates its effectiveness, safety, and impact on patient experience and of integrative medicine approaches. We now have 32 members including UCSF. I'll happily note that. And we largely have been focusing on observational research, but now have added randomized controlled trials to our portfolio. And you can see here in the blue are the number of states that have BraveNet members. Can you see my pointer? Is that showing up? Well, a lot in California, and so I think we have like 6 members in California. So it's disproportionate. I think how many sites are in California, but you can see quite a nice distribution. We're still looking to at some point include more U.S. sites. We have included now a site in Australia, Canada, Korea, and Brazil. And you can see here. Oops, go back. 4 of the members are members of the UCs, so UCI, UCLA, UCSD, and UCSF, just to point that out, the top left. So acupuncture in an outpatient clinic. And again, with the Osher Center, I'm sure there's been a lot of experience with that. So it's spacious, it's relaxed, it's quiet instrumental music, it's softly lit, probably even smells pleasant, maybe some lavender or other things. So it's really a lovely place. It's not soft lighting, it's quite important. Those non-specific effects are really quite lovely. Now in the ED, I've kind of taken the faces off these people since I left my former institution. But in the ED, it's cramped, it's stressful, loud beeping / screaming, brightly lit. The fluorescent lights are still in the ED, and they're roundabout everywhere, and offensive smelling. So you might hear some screaming, you might see some smells. So it's not that same environment you're seeing in the outpatient clinic. So can acupuncture and ED work? So a couple of years ago, now in 2016, this is on Atlanta Health, we published a observational study looking at acceptability, adaptation, and clinical outcomes of acupuncture. This was really, I had an NIH grant, and we had a supplement to the first author, Adam Reinstein, who was, he had gotten a CAM practitioner admin supplement to my grant. And we actually deployed him down there in the Abbott Northwestern ED roughly 50% of the time. And over the course of a year, I think he saw about 200 people, and we published this and had very nice results, both on pain and anxiety. So that prompted us to think, and I started with this where we just deployed it, because if it didn't work when we deployed it outside of a randomized controlled trial, then I really wouldn't want to proceed. So this actually spoke to providers actually referred for acupuncture, and they had a referrer in this case. So we really had a lot of referrals, like 75% of acupuncture, of providers referred for at least one acupuncture session over the course of a year. So, and the patients really enjoyed it. So, and we saw some really nice changes. So that told me that if we actually ever can get acupuncturists employed in the ED, then perhaps we could actually have some benefit. That led to a small study, which I'm not going to focus on, but this study, which I'll talk about today, is the ACUITY study. This is our methods paper that was published in Journal Medicine. And we just published this past month the results study of the ACUITY study. So let me get into starting off before we get to it. No, the talk's not over, but before I get into it, I'm the representative of a team. There's a lot of people here involved. So I'm not UCI, but Albert Einstein was the coordinating center, UC San Diego, Vanderbilt, and Case Western University Hospitals were the recruiting centers. We have someone on our independent monitoring committee who's I see Maria, that was on the call today, so she was great, helped out with us on that. And then we had some collaborators at UMass Medical School, an acupuncture expert, Arya Nielsen, who's amazing, really made a great difference. And this was funded by NCCIH, so that's our program officer, Wendy Weber. So there are 3 sites in our coordinating center. So we're getting geographic diversity across. These are 3 BraveNet affiliated groups. The aims of this was to develop a responsive acupuncture intervention. So what does that mean? I won't talk so much about that today, but essentially, rather than having any acupuncture points be available to the acupuncturist, we actually had a Delphi process where we worked with individuals, acupuncturists who were working with acute pain, and queried them to understand for different pain locations, because we're looking at a very heterogeneous pain location. We look to see what points they would use for certain pain locations, for example, like lower back or neck or headache or things like that. So we used a responsive acupuncture intervention. I won't talk so much about that, but it's actually a little different than what has been done previously. So we're actually pretty proud of that. We look to implement. It's a feasibility RCT. So this is really not to look at efficacy. This is really to see, can we take that small randomized trial I ran at Line of Health and bring this into 3 larger EDs. And then we used qualitative interviews and structured observation in more of a mixed methods approach. Not mixed methods explicitly, but we wanted to use qualitative interviews to understand what were some of the aspects from both providers and patients on their feelings. And then structured observation, we had our group, Allison Perez was our investigator at UMass, who went and watched the acupuncture happening at the EDs for several days at each site. So the treatment, again, acupuncture for pain in the emergency department versus usual care. It was 1 session. It all happened in the ED. Usual care was whatever happened in that same time frame. It was just an ED visit. Outcomes were assessed post-treatment, about 45 to 60 minutes later, and then a follow-up was at 1 week post-ED visit. Measures of success would be recruitment, retention, adherence to the acupuncture manualized protocol. We had a lot of criteria. So again, this has a pragmatic feel, but it is an RCT. So we were looking for adults only. Some of our instruments were only in English, so we get only in English. We had individuals who were 3, 4, and 5 on the triage scales used in the emergency department. 1 and 2 are very acute, so they wouldn't be appropriate for a non-pharmacologic treatment. So again, we're looking for people who are not urgently having like chest pain or a gunshot wound or things like that, but it's really looking at acute musculoskeletal, back, pelvic, non-cardiac chest pain, abdominal, and headache pain. And they had to have had to have actually a greater than or equal to 4 on the 0 to 10 numeric rating scale. And so that was, we wanted to have some kind of level of pain to include in the study. Exclusion, we had a lot of different things, especially this study happened. We started recruiting in late 2020. So you can see in the bottom CO is an aspect of this, but fever exceeding 100, leading to maybe some other aspects that need to be taken care of in the ED. Chief complaint of psychological or psychiatric concern. So sometimes people come in, as you might expect in the ED, and they're not suitable for participation in a clinical trial. Migraine, oftentimes in migraine situations, a bolus is given that has pain relieving aspects. So that could influence the pain relief that we would actually expect to see in the study or hope to see. Current pregnancy. One of the things that we're working on for the future study is this idea of self-reported or documented opioid medication taken orally within 4 hours. This might be what someone might have taken before they had come to the ED, or even in the ED before our study coordinators got to recruit the individual. And we really did that because we didn't want those medications to be influencing the pain scores, and therefore we're taking credit for the opioid medication. So we're really trying to make sure that this is a cleanish sample in the real world of the ED. Joint dislocation, bone fracture were thought not to be so suitable for acupuncture, and then COVID, confirmed or suspected COVID. This is a study flow. I'll go over it very briefly. Admit to the ED, they're triaged with the ED staff, and then we pre-screen them. And these are all Epic shops. So there was a track board, so we could actually look to see if the individuals were eligible. The patient was roomed. Now, ideally, why this is important is in COVID, the EDs were very, very, very busy. And so patient room should be in quotation marks because we actually had individuals who were in the waiting room area, or in a private part of the waiting room, in the halls, in curtained areas, and in rooms. So it really was roomed is in quotation marks because it's not like in a room by themselves or in even a curtained area. The idea was have needles will travel. We really want to have this be as little burden to the staff, the ED staff as possible. So we really want to work with whatever space we could find. The ED provider assesses the patient and if eligible signs an approval form. Again, that's because people are going to the ED not to get acupuncture, but they're going there for care. So we want to make sure, obviously, they get assessed in the triage, but also the provider says, yes, this person can could participate in a study, there's no need for them to go to emergent care. Study staff completes the screening, patients consented, randomized, patient-reported outcomes collected. We used the iPads, and we had all the baseline scores were collected, and as well as the longitudinal scores on iPads, such that we'd hand the iPad to the patient, they'd complete the questions, and then click and it would hand this iPad back to the participants. So we were blinded to scores. We could not even tell what the scores were. So that was, we really wanted to make sure that patients could feel confident and be honest about their pain scores. They then receive acupuncture. So one of the aspects of acupuncture was to participate in a study, this whole part here was, could the patient not have an opioid or a pain medication or any pain treatment for an hour? So we had, the idea was, to be included in the study, you had to have, to be eligible to have no treatment for an hour. So if you had some emergent care that needed to happen, you weren't a good candidate. So that was why we don't want to have the provider saying, yes, they could withhold pain treatment for an hour. Therefore, again, we want to influence the acupuncture or usual care before the baseline was collected. Obviously, usual care is going to happen after the baseline. That's going to happen, and then about an hour later, then we collect the pain scores, and then go back to usual care, and then are discharged. And then acupuncture happens post-score. Usually go back to usual care. So whatever's going to happen to them in the rest of that stay, and then they're discharged. So again, we intervene a bit into the natural flow of the ED, but not disproportionately. So recruitment. So our big part was, can we recruit? So we had a lot of things to be mindful of. So, and this is a lot of information, so let's quickly go over it. So at university hospitals, we had 473 people screened. So our goal was to recruit 65 at each site. That was the overall goal, and in about 6 months. So 473 screened, approached 220, enrolled 61, and we did that because Vanderbilt was a little behind. So we had each site shoot for 55, and actually it was 55 per se, excuse me. And so UH caught up a little bit to because Vanderbilt was a little behind. 27% recruitment rate. Vanderbilt, you can see the numbers here, 16.3 recruitment rate. UCSD, 49.1% recruitment rate. So again, overall, we're at 26.1%. And again, you would think it might be higher if you're a clinical trialist, but in the ED, obviously people are not going to the ED for acupuncture. So that was part of the goal, was to understand, not necessarily for effect sizes, but just to kind of help us plan for future study, how much time we would take to recruit using this kind of information as a guide. Now you can see variability. UCSD at a 49% recruitment rate, whereas Vanderbilt at 16.3. So again, not too many differences. One difference was Vanderbilt, we used ED staff for research assistants, where at UH and UCSD, we had integrative medicine study coordinators serving as that. So we feel like in the future, we'll probably use that across the board, so there's consistency, but partly that was what this whole idea of the feasibility study was. What can we learn in this pre-definitive study to learn some things? So 26% was fine. Retention, 61 were enrolled, pre-scores 100%, 98%, 0.4. What happens between pre and post is things happen. People go for imaging, they go for other types of things. A couple of people leave against medical advice. So just that is life in the ED. Vanderbilt 49, 98%, 95% had post scores, 85% at UCSD. That's where we get to the iPad. There was a glitch in the UCSD red cap such that the first few patients, because we couldn't see the scores, there were no scores being entered. So we then figured that out and fixed red cap. So again, this speaks to the idea that we're completely blinded, but we did fix up pretty quickly to ensure that we had that all the pre-scores. So again, we worked on some of the kinks out of this in the feasibility study about what we would do in the future. So actually 94% and 91% met our thresholds for success. So demographically, this is interesting. So again, it's a lot of numbers here. I'll kind of talk you through it. So overall, we had more females than males, as you'd expect, and it was pretty decent. There was no difference across the acupuncture and usual care groups. Again, 151 people had pre-scores and post-scores and had that. Age, again, 44.4. The big point here is 44% of the population were African-American. And that was that was evenly distributed across both groups. And that was really based on the university hospitals. Cleveland study, there was 80% African-American participants at our university hospitals setting. So that again was one of our goals. Was the idea was to ensure that integrative therapies in this ED setting are broadly across the racial and economic spectrum of the US. So we're happy to see a more proportionate African-American participation than we usually see in integrative medicine studies. Ethnicity, 13%, that was largely driven by UCSD. So we're happy to see that, again, we compared to most of the ED studies, except for a more recent Duke study, we really are unique in having such a high proportion of African-American participants. Just going over that general, okay. The same thing with education. You can see here, no high school or high school equivalent. We had 35.8% low education. Low income, we had 61.6%. And then Medicaid was 26%. And so again, and then no insurance was 5.3%. So again, we're touching people who might not be touched in more exclusive integrative medicine clinics. This is the location. So again, we took whatever pain condition that it couldn't be emergent chest. But we were looking for all pain locations. And again, people wondered about that. And we talked to our ED physician that said, it'll be great, Jeff, to have this study be successful, but if you're just doing this and have it being successful for one or two conditions, it's not going to be that useful to us. So we would love acupuncture, if it were to be used, to be studied in ways that we would use it in the ED. So we adopted that approach. Back, upper and low back was the highest proportion. Extremity and abdomen were our top three. You can see prior acupuncture was 24%, not different across the two different groups. And pain intensity at baseline was 7.3. So again, our approach worked. Again, there was no difference across the acupuncture and usual care group. We also measured pain, anxiety intensity, which was 4.3 on the same 0 to 10 numeric rating scale, and no difference between the acupuncture and the usual care groups. So what did we find? So again, you can see here's our pre-scores on pain intensity, 0 to 10. So 8 is high. It's a high pain score. I would say it's severe. So 8 with a standard deviation of 2.1, 6.4, 7.7 across all three sites, average of 7.4. Usual care, 8.1, 6.4, 6.5. So you can see there's a little bit of difference, just but randomly, and 7.1 on average. And the one thing is interesting too is Vanderbilt had a lower pain score. Again, it's hard to explain. We're still exploring that, but again, the same eligibility, the same strategy, the same protocol. So it's I guess why, and this is why I love multi-site research. It's complicated and it always throws a curveball at you, but it does. Vanderbilt is a different spot than his university hospitals, than his UCSD. So again, it does speak to why multi-site research is important. So post-acupuncture, I'll go through this a little more quickly. Average of 4.8, usual care, average of 6.4, minus 2.6, minus 0.7. We are prohibited against doing any statistical testing because it's a feasibility study. We had to promise them, and we didn't do it, that we wouldn't compare those two because we were not powered to detect differences. We are really looking for recruitment, retention, and of course, some of our other aspects I mentioned at the beginning. So one of the aspects I mentioned at the beginning was a protocol. So we published a protocol about our Delphi process. So I talked about that. So we published that. We also, and this is a little bit hard to see, but you can see if this is a all acute pain, these are the points, these dark green are the points that were lead points. The points in light green down here, the auricular points, are tier 1, which meant they were should be recommended as well. And the points in yellow are additional points that could be done at the practitioner's discretion. Now, because the practitioner is seeing the patient in the real world, we also allowed the practitioner to use any point that they thought would improve the patient's outcome. And they chart all this in REDCap. So we wanted to make sure we were doing all of this. Actually, no, They didn't do med cap at the first 2 sites, they did in the 3rd site because we were rolling the acupuncture delivery out. So they noted all this on paper forms, the first 2 sites, and the 3rd site, they used red cap and just to test out whether we could get that functioning well. But it worked out quite well, so it was good. The nice part about this is, again, there's some direction for the acupuncturist. We're not leaving them to their sole discretion, but there is discretion for them. So we like the idea. It's a manualized acupuncture protocol. It doesn't restrict them, but allows for some consistency across studies. So we published that paper as well. And we think of it as expanding the global standard or the gold standard of stricta and concert guidelines. And briefly, in this, we saw the number of needles used on average was 13.2. It didn't vary that much. The needle retention was 23.5 minutes. And again, it was very similar. UCSD was a little bit longer than the others, but not just dramatically. And session length was about 40 minutes. And again, roughly anywhere from 43 to 36 minutes with the mean. So again, that's really important we met our goals. So again, Aria Nielsen did a summary of this, and she had some staging. So we got 4 different concepts. So she had them staged, kind of doing some palpation, assessment of the injury. Needle sites, we expected 1 to 18. That was based on the Delphi group. And the fidelity definition allowed for up to 20 needles. We had some where they had 23 needles, I believe. So we didn't have complete fidelity on that. Retention time, we're looking for 15 to 30 minutes. We allowed for plus or minus. So anything from 10 to 35 minutes met our needle retention time. And we had 96% of the sessions meet that. Session length, we're looking for 30 to 60 minutes, plus or minus 10 minutes, or anywhere from 20 to 70 minutes allowed for that. And again, we're at 97.7. We had them give recommendations about drinking water after the acupuncture session. That happened 97.4% of the time. And then looking at the completion of their session forms. So did they complete the forms? And we had to have 95% of the forms being complete, and we had that 100% of the time. So our total fidelity was 98.1%, which we felt really good about. And again, one of the cool things, I alluded to this earlier, but the ideas about the conditions, low back pain, abdomen, leg, head being the top conditions. The location of treatment, private room was 31 times, semi-private room was 70% of the time, common room, waiting room, or hallway, 41. So again, you can see this idea in COVID, it was a bit of it added a little more chaos to the ED. But again, we were able to recruit on time and get all the things done. Even Vanderbilt being a little delayed, we were able to pinch hit with university hospitals. And again, some of the limitations was the position. So these are fully clothed people. Somebody's in a chair, not oftentimes laying down because they were in a private room, only 31 of the times. We really had some conditions where time was too short. With the acupuncturist thought, we had 2 people on the phone. I don't know what happened there. Limited access to points. They couldn't get all the points they would love to have because of either they were seated or they were clothed or things and other interruptions. So again, it really was a real world study to say the least. We also then looked at provider perspectives of acupuncture. So at the end of the site's recruitment, we had appropriateness. We asked them about the appropriateness. How appropriate was acupuncture to be in the ED? 42% said was very appropriate or appropriate, and neutral, inappropriate, or very inappropriate, excuse me. So appropriateness was about 42%. We asked if it was helpful, it was 56%. So it's kind of word shift from appropriate to helpful, shifted things in the provider's perspective. That was one of our goals of the study, was to assess that. We also assessed the perspectives of acuity. So how satisfied were we with the study? 75% were either very satisfied or satisfied, which was nice. And then, we looked at to see how much of a burden we were. Now, I mentioned before that we were recruiting. We were recruiting people that were coming to ED for clinical care and to participate in a study. 72% said, almost 3/4 said we were not a burden to them. And we only looked at the 32 of the people who actually had experience with us. So again, in the ED, we had other people, 125, 124 people respond But if you didn't know acuity, you couldn't respond to the survey. So we really want to make sure they knew about the studies. So, excuse me. So we didn't survey them. What do patients think? So we asked them at the end, the post-treatment, and we looked to see. So this is the acupuncture is in black. So we had acupuncture is about 42% were satisfied with their pain management at post versus 18% of usual care. And treatment satisfaction with treatment at post was almost 80% in acupuncture and about 25% usual care. So again, the patients in real time were appreciative or satisfied, let's say, with the acupuncture treatment. Was it a qualitative study? So of the 83 randomized to acupuncture, 58 agreed to a qualitative interview. 25 of the 58 agreed actually completed an interview, and demographics were similar to the feasibility study participants. So I'm not going to go through that. The guide was created based on literature and study team input. One team member conducted all interviews after training in either Zoom or telephone, and they were either 30 to 60 minutes recorded and professionally transcribed. The analysis began with the initial interview. Iterative changes to include we actually made some changes to interview guide. We did coding. Actually, Allison was the key of this stuff. The coding scheme as new themes emerged to decrease redundancy. The full data set was coded by 2 authors. The coding and interpretation discussed in weekly meetings, and interviews continued until data saturation was achieved. So what did we find? So a couple of the thoughts that came up was prior experience with acupuncture, curiosity, the long ED stay. One of the comments was, I was like, why not? I'm literally lying here doing nothing. Also, why asked why they participated. I understand the necessity for holistic treatments as opposed to treatments with like drugs. Desperation, at the point you were just trying to at that point, you were just willing to try anything for your pain. They were speaking in the third person, of course. And altruism. If the research will help benefit someone else and just lying there doing nothing, do your thing. Patient experience. Most patients reported a positive experience, very positive interaction with the acupuncturist. They thought they were caring. It's just like she just showed up and cared about resolving the issue. Another one said they had initial needle phobia dissipated. I really don't like needles, but it was really all right. So one of the things as we were going through the study, we realized that not everyone had exposure to acupuncture. So we developed a process where we had acupuncture needles taped onto a card, and we're showing individuals what acupuncture was. So it wasn't as if there's going to be 7 or 10 or 15 hypodermic needles in their arm. It was going to be small hair-like needles. So that really helped too to understand what acupuncture was and what it would mean. Improvement with well-being. It helped me a lot with anxiety and the getting too hyper type thing. It really didn't help with the pain, but did put me in a relaxed mindset. And a few experienced pain or unpleasant sensations. When she put one in my foot, I felt like something electric needle, like the shock. I'm going to say it was the chi. But again, that was one of the things we wanted to note as well. And finally, overall well received, the patient conclusions. Most reported improvement in pain or sense of well-being or both. A few did report unpleasant sensations. Unexpected to be offered acupuncture and ED. They felt really like this was nice. They felt cared for. And they were able to include some needle fear. We were able to include some people with needle fear because we, even though we explicitly addressed this during the consenting process, people just, kind of didn't know what needles were like until we actually showed them. And then findings suggested the flexible approach, adapting to conditions and space in ED should be followed in a definitive trial. So the summary, getting to the fun part, is recruitment. Despite launching and conducting the study during COVID, recruitment achieved was 26.1%, which again, not stellar, but not abysmal. So we'll take it. 80% of subjects at Site 1, which is University Hospitals, were African-American. 45% of subjects were Hispanic at Site 3, which is UCSD. And low-income and public insurance were enrolled at a high rate. Retention, post-treatment rate was 91.5%. Adverse events, we monitor them very closely in the ED and throughout the follow-up. We actually used what the CDC used to monitor COVID-19 vaccines. So we got a lot of the same style of questions. So we got a lot of pain still here, or now my ear hurts, or things like that. So we had A lot of minor AEs. We had 2 serious AEs. None were linked to acupuncture usual care. One person died. They had, I think it was a liver disease, and one person had a stroke after the fact, but that was usual care. So nothing was linked to the acupuncture or usual care. AEs were 60, mostly mild and unexpected, or expected, excuse me, linked to acupuncture usual care. So again, my pain is still, my back still hurts or things like that. Acupuncture intervention, we felt very good about the response of manualization. 98% of one were aligned with the protocol, which was good. And the uptake, providers found acupuncture to be appropriate and more helpful. And acuity was not a burden. And then acupuncture patients were more satisfied with pain management and treatment than the usual care. So next steps, this sets a strong framework for a future definitive study called the UG3, UH3. We want to propose a superior study of acupuncture for usual care in 4 to 5 EDs associated with BraveNet clinics. And we need a larger sample size, and we're working on that application as we speak. So thank you for your attention, and I'll take any questions that you have. Thank you. Any questions? Oh, yes. Hand clapping. Oh, I'll take that. Sure. So any questions? Hard ones, easy ones? What can we talk about? Thanks, Shelley. Any questions? It can't be this easy, right?
I'm curious to hear more about how COVID ended up affecting things. It seems like you were able to meet your recruitment goals anyway. Very impressive that you did a non-COVID study in an ER during the pandemic.
Yes, that was not by choice. So this part of the gray is because the COVID study, because COVID happening, it was stressful. I mean, we had weekly meetings with the emergency department PI. So one of the things I always do is have a ED physician champion at each center. So they were the ones that really helped us to keep motivated, to make sure that the staff understood what we were doing, just to keep cheerleading all the way through. So we really owe a lot of it to them because they were on the ground. We had one of the questions came up was how did the staff look, how receptive with the MDs to having a study happen in ED? I would say they liked it. I mean, I know the advanced practitioner, the APPs, really got into it. But the MDs, we really didn't have any issues. And again, by having that MD champion, we're able to work with that MD champion to answer and address any questions. So I would say it went as well as any study in the real world could. And with COVID and other things happening, so there was no stress happening besides our study. I'm joking, but yeah. Yes, Jan, sorry.
Hi, so bed availability is a hot button issue in a lot of emergency departments. Did you guys run into issues where the treatment had to be interrupted or recruitment had to stop because bed availability became a big issue?
Great question. And I kind of push this idea of have needles will travel. So we didn't require a bed. We didn't want to have a room be held up. And so that really, really helped the idea of recruitment. So at one point, some of our MDs said, well, here, go in this nice little room where there's just the spinning of bloods and things. So, no. We want to be wherever. We don't want to be a burden. And that really helped. So we didn't get in the room of, we mostly, well, I would say we never got in the way, but we mostly didn't get in the way of bed availability, the flow. I know there's not a metric necessarily to talk about the flow. I mean, we're looking at such a small number of participants at pretty busy EDs. So we're not going to change their bed to med ratios. We're not going to change anything that they're really interested in. And I think they're very compelled to participate. They really thought I think a lot of the MDs really appreciated that we're trying something different. So going back to when I started the study, one of my colleagues at Align Health who happened to be a person from college, said, Jeff, I'm tired of narcotizing my patients. This is in 2013. It's like, can you do something? And can you assist us? So that kind of started the ball rolling. So I think there's a whole body of providers who are interested in trying something that's safe, effective, and evidence-based to relieve pain in their participants. And the other part is, I think patients are also interested in participating. So one of those quotes was they didn't want to receive a medication. So I think there was an extra advantage to doing it that way. Thanks for the question. Any other questions? Oh, let's look at the chat here.
Yes, actually. Hi there.
Yes.
I'm dialing in from Edmonton in Canada, and I'm sorry I was about 15 minutes late, but I was fascinated to learn about your trial. And congratulations for getting this done in COVID. From my experience with trials, which is very limited, it seems like whenever you study a condition, all of a sudden nobody has that condition anymore. Never mind the barriers of COVID. I do a little bit of acupuncture, but only in pediatrics, in the pediatric emergency department. And I know you just recruited adults for this. I missed the first part of the talk. Did you, for the providers, were there any who were MDs as well as acupuncturists? Because I've met a few who do both, or did you just have LACs?
Just LACs. Yeah, great question. I should have mentioned that. Just LACs. And there were 2 individuals at university hospitals, 2 at UCSD, and only 1 at Vanderbilt. They only had only one acupuncturist at the time. And I think they're trying to get more because they're having such a interest. So it was all LACs. Yep.
Okay. And then were you studying only pain, or were you looking at any other outcomes like nausea, vomiting, or?
Just pain. So
Okay.
our goal was pain. We also measured anxiety, and I didn't show that, but we did see a nice improvement in anxiety as well. So we measured comorbid pain intensity and anxiety intensity, and so we saw both improved.
Okay. And then in terms of the qualitative for the providers, do you know if did you get a sense of would people recommend acupuncture for after the visit? So for instance, there's some where the patients have experienced some benefit, or they're curious about acupuncture. Sometimes I'll recommend that they see somebody in follow-up. Did you get a sense that this maybe changed the attitudes of the physicians?
It's a great question. I'll ask the interviewers. I don't really remember that. So, but I want to say yes, just because I feel like that was the general vibe. But I don't want to misconstrue that. But I think that's a lot of this was, when I actually started the study, we thought that we were talking to NIH about like a dual randomization, randomized in the ED, and then and then randomized after the fact to receiving like 3 or 4 acupuncture sessions in a clinic. Now the Duke group has just done that successfully. They're in the midst of doing it. So Stephanie Euchre, the paper just published this year. When I talked to NIH, I said, too complicated. You're never going to get this through review panel. So we opted just to stick to that acute environment. So that's what we did.
Thank you very much, and wish you
thanks for the questions.
Success.
Thank you. Appreciate it. Maria.
Hi, Jeff. Thanks for a fantastic presentation. I'm really absorbing the fact that you said you started this work in 2013. Is that right?
Yep.
So such a tangible example of implementation science. I always talk about that big gap between, basic findings to getting it out to bedside and communities. And so I'm really curious to hear your thoughts about next steps, accelerating something that's really promising, and maybe a little preview of your UG3, UH3.
Oh, absolutely. Yeah, I mean, I think you're exactly right. I mean, I think the implementation, it was not the 17 years from results to implement in the clinic. We actually reversed it. We started in the clinic to said, if it's ever going to work, I want to know right away. I don't want to waste my time. But it really was that process of having the idea and having this colleague who happened to be the ED medical director saying, look, why don't you help us? This is 2013, we're struggling with opioid addictions. Like, okay, we'll do something. So we started with that deployment of my RO1, and then did a small philanthropic funded RCT, and then obviously this study. So yeah, we're excited. The papers we still have a few more papers to write, but we feel like there's something tangible here. We're in the process of doing the UH3 process, which is going to require us to, amp up the sample size to meet the goal. So in the literature, 1.3 units is the clinical standard for acute pain relief in the ED. So we'll need to use that for our powering. So, but we're in the midst of doing that. I'm having a meeting 15 minutes after this with the team. So we're gearing up with that. Diane McKee, who is my MPI in this, Bruce Barton, who's going to be the U24 lead at UMass, because those UG3 and so for you, those of you who don't speak the ABCs of grantmanship, the UG3 is a 1-year phase where you develop your process to set up a definitive study. And we're going to probably do a pilot study to kind of test our new procedures again. And then it's a go, no go. If you don't meet your goals, the UG3, you don't go to the UH3, which the UH3 is actually where the happening of the study is. So, so we're preparing for a 5-year combined grant, and then U24 is a coordinating center that aligns with that clinical group. So it's got 3 different pieces to it. So it's kind of cumbersome, but it's really fun because it's a whole new set of opportunities to really understand, are there predictive characteristics of who responds to acupuncture ED? Are there age, gender, pain location, comorbid anxiety? All these other things can lead to it. So I feel like we're really this gift of this multi-site feasibility RO1 allows us to work with the kinks. We learned a lot. We've got our red cap already built. So we've got a lot of the work done to prepare for this next step. So I feel like we're really in good stead. Again, knock on wood, you always have to wait for review panels to see what they say, but I'm persistent. So that's always a good thing too, I guess. And thank you for serving on the committee, committee. That was very important because we needed to have an independent group to make sure that there was no risk and other things. So I audited you by that you and other folks had served on that, which really helps us out. Thank you for that, Maria.
It was fun. Thank you. I'm
Thanks.
also curious about, the part that you said about patient quotes where they were saying, yeah, I mean, I'm bored. I'd be happy to enroll in the study. I'm curious about how they felt about randomization.
That's a great question. I'll have to look to that as well. I'll look to the notes. I know it's always tricky with randomization because people are looking to, they're hopeful, as we are, that the intervention that we're seeking. So I want to say they were disappointed, but I think we did a good job of positioning how this was going to be really impactful for the future. And so I think we got a good rate. 26% was maybe less than I was hoping for, but again, with so much going on in the ED at that time, I mean, literally it was in the hallways. I mean, they were trying to do acupuncture when people are going by. So again, it's not that beautiful room and where it's smelling lavender. I mean, it was almost even worse than that picture that I showed. It was really, it couldn't have been like more challenging conditions, and that acupuncture worked in that environment, I think is really positive. So you asked a question about, did people feel bummed out about the randomization? I'm sure they did. And again, what I typically like to do is to provide at the end of the study is something that they leave with, even in the usual care group. So we did go out, I didn't show you the 1-week data, but we had ear seeds put on as well. And we had the acupuncture patients stimulate the ear seeds. So we did see some improvement in pain at 1 week. So the idea of, is it acute in the ED and can it persist, a week? we did, we will probably have to go to a month. We're getting some of the concepts of people saying, well, we really want to see long-term changes. So, long-term changes with one acupuncture session is really challenging, but we may have to push ourselves to do that. But so at that 1 month period, I would want to give the usual care group then some guide about what they could get, maybe, or a free session of acupuncture or something to just appreciate their participation. So it's a great question. It's always, again, with this group of people too, these are a lot of the folks you saw were even though 25% of people had acupuncture previously, these are people that, there weren't a lot of extra funds to do a lot of different interventions that they don't have money for. So I want to make sure we do right by them too. See, I'll look in the chat. You mentioned looking for additional sites. Cook County Health recently completed a 3-year SAMHSA study on acupuncture in the emergency department. How will we participate in your ACUITY study? So Cook County HHS. So are you involved, Lisa? Are you involved with the Duke study? They also got a SAMHSA grant to do their.
I think I'm unmuted now. Yes.
You are. Yep.
Yes.
You are.
Yes. So we were in the same study that Duke recently published and presented their material from. Yes.
You were part of that study, or you also got funded in that same cycle?
We were in that same cycle. So we were funded at the same time as Duke. And so they just recently published a manuscript, and we have one in the works ready for publication. Actually 2 that we're working on right now. So we just completed, our enrollment and are publishing, recently or soon our statistics then.
Okay. And is Cook County in Chicago?
Yes, it is. So
Okay.
it's Cook County Health, we're a safety net hospital, and work with a diverse population. And, we did have also some good response with our study, and we're looking forward to publishing.
Okay, great. Maybe you can just put your email in the chat, and I can reach out to you.
Okay, great. That would be wonderful. Thank you. And I so appreciate your work. It was a fantastic study.
Oh, good. Thank you. Yeah. Well, I mean, it's tricky to do.
Yes.
In the ED, but it's really compelling. I don't know about you, but I mean, I really find that environment to be completely compelling. I know, Maria, you do a lot of work with underserved individuals in real world environments, and just, I don't know, it just feels like you're doing something different. And that's in research, those environments is not easy, but it's also, it makes you feel like people are benefiting or could benefit in the future. And ideally, I'd like to have acupuncture in every ED in the country. That's my goal. No pressure.
Yes, I agree. Yes.
Okay.
Thank you so much.
Of course.
There are a couple other questions in the chat. I don't know if you can see them.
Hold on.
There, one's farther up. I'm going to read the farther up
Oh,
one.
please do. Okay, thank you.
Yeah. From Dorothy, unless you want to come on and say your question out loud.
Yeah, I could just ask. Sorry, I was just curious, did you all experience any pushback or anything from approaching patients in the ED at all to do acupuncture?
No, so that was the point that I really wanted to make clear, that we knew that we were a secondary partner in that environment. The patients were there to receive care, emergency care. And what we found was the more we were embedded, we really had space, at least in 2 of the sites, space right in the ED, right in the midst of things. And in one case, in the university hospitals, the advanced practitioners would just say, "Hey, I've got someone." So they got engaged in the recruitment because they saw changes in their patient, and I think in one patient, then they just got motivated. It leads me to a story back in the 2013 study when we were at Atlanta Health. It was slow going to start. And again, the medical director was a friend of mine, so he was referring. And we had the acupuncturist just positioned in the ED. And there was one case that the acupuncturist told me, said he was waiting outside a room. A physician came out of his room frustrated, like, oh, this person just driving me crazy. And the acupuncturist said, hey, can I try? I said, sure, go ahead. And the acupuncturist went in, and the physician waited outside the room for him. He's like, oh, I'm gonna see. And when he came out, he said, great, the person's ready to see you now. His pain went from, I'm gonna get this wrong now, but like 10 to 3, and anxiety went from 8 to 4 or something like that. And then it really changed. Then the provider went in, and it was a much better circumstance for him. He came out and said, okay, I'm, okay, I'll refer. So it's that, it just, when you saw that, and then when they see it, when the patients are benefiting in real time, it really does help you for them to appreciate it, it seemed. Not every time, but certainly that was one example where I was like, okay, the skeptic of all skeptics was, his patient benefited and really made his job easier.
That's really cool. Thank you.
Yeah. Let's see anything else. Okay. So I think the recording will be somewhere. I know there's a note about recording, so I'm not sure.
Usually the recordings are on the UCSF Osher Center YouTube page a couple weeks afterwards, right, Julia?
Okay.
Maybe more than a couple weeks at this time of year, but coming soon.
Okay. Yeah, and again, because this is funded by NIH, this is why it's really important to get out there and share this. So this is, they don't want to fund studies that just sit on the, and not be noted. So again, I appreciate the invitation. Again, I really love talking about this study because I think it's really important to get the word out. And again, it's like, Maria, you've done really hard work in difficult settings. So I think it's really, I think it's important to talk about our work and to share what works and doesn't work. So fortunately, we made some good decisions about this idea of not having to need a room. Had we done that, that would have really made the study as a whole really challenging. So that was a bit of luck and just me being also persistent about, I don't want to be a diva. I want to make sure we can be whatever is needed, so, and help out. Okay. Well, thank you guys for the invitation. I really appreciate the honor, and I hope everyone has a good holiday, and